Um, yeah,
Assalamu alaikum. My name is Imtiaz Khaisar. I'm one of the old musalli of this masjid. And because of initiation of, he took the initiative to take this kind of program for our adults and senior. And I have heard his program in Islamic Foundation. It was very interesting, very interactive. Any question you can ask him, he will give you an answer. Dr. Muhammad Ahmed is a nephrologist. He is practicing in Renal Care Limited in Hinsdale. He is also an associate professor of Midwestern University in Downers Grove. He completed his DO degree from Midwestern University and completed the residency and fellowship in nephrology and hypertension from Loyola University. He's also completed his fellowship and critical care medicine in Mayo Clinic, Rochester, Minnesota, which is the highest level of medical university. I can say that. I have listened to him couple times. He will explain you very simple language and understanding language and will answer any question and interaction. He's also a member of National Kidney Foundation of America. He is a product of MCC Chicago, like Brother Sabil Ahmed. I was involved in MCC Sunday School for last 15 years in 90s. So I know these people, they were little kids, they grown in front of me. Mashallah, our community has a lot of potential. Our communities have a lot of doctors, engineers, but we are not taking advantage of them. So my goal is to use the maximum benefit from our own kids who are very qualified. We don't have to look outside. Mashallah, we have attorneys. Brother Azam Nizam is also here. So we have to look for our community first. Then we don't have to look for any other community. We have a lot of talents. Before I take a lot of your time, I request Brother Muhammad Ahmed to start your lecture.
Assalamu alaikum. So we're going to try to keep this as foundational and as simple in terms of our discussion so that I want everyone to kind of follow along everything that I'm saying because this is not meant to be a conclusive crash course in medicine. It's really meant to be a framework in which in giving you a way of how to think about your own health so that you're educated when you walk into a physician's office. You know what things to look at, you know what the signs and symptoms are of kidney disease, how that can be diagnosed, what can we do to prevent it, and if you have kidney disease, is there any hope there to help you improve your kidney function during your lifespan so you can avoid the need for dialysis, which we'll talk about briefly. So, the first concept that I give my patients, both Muslim and non Muslim, is that we should all think of our body as a amanat, a trust that God has given us. So, I ask my patients the question, when you were gifted with a child, and the child would start crying, would you wait till the diaper rash developed before you change the diaper? Or the first time that you would hear some sort of cry or some sort of indication, you'd run there and you change the diaper? Not, I haven't gotten one person that said they would wait for the diaper rash. And I said, similarly, as God gave you this trust to take care of the child, He also gave you this trust from your head to toe, which is really an amanat, the trust that God has given you to take care of and to nurture throughout your lifetime. Not only that, He's given us a manual of the Sunnah of the Prophet ﷺ that educates us on what we need to do to maintain that trust and to nurture that trust. So, with that being said, when my patients come to me and they have advanced diabetes, they have advanced high blood pressure, they have symptoms and signs consistent with blood vessel disease, heart disease, my first question to them: are you going to wait for the first heart attack to take things in your hands, or are we going to take this and prevent the first heart attack from happening, prevent the stroke from happening, prevent the first signs of kidney disease to occur? Clearly, we as a community, and I know that when I was growing up and I would go to a physician's office with my parents, the interaction and sort of the way that the communication occurred was simply you go to the doctor gives you medications, he checks labs, and they say take this medication and you're on your way. But I think we've come a long way from that, and I think we have to recognize that medicine is not a black box. There's a lot there for us to understand. There's a lot there for us to follow, and there's enough there for us to become advocates of our own health so we can be intelligent in the decision making and not be a victim of decisions, but actually partake in the decisions that our doctors are making for us and with us. So, with that being said, with those kind of introductory comments, everything that I say, there are side branch points of that you could talk for hours. So, I'm obviously not going to be able to be as comprehensive as I'd like to be, but I would like to give you a framework in which to think about your kidney disease. This is not. I don't have any slides. This is not a presentation that these are kind of the comments and things that I tell my own patients, and I want to share with you. So when we look at our solid organs that we have in our body, we have the brain, we have the heart, we have the lungs, we have the kidneys, we have the GI tract, solid organs that we have in our body. All those solid organs, in order for them to live their normal lifespan and to be able to function as they're supposed to based on the lifespan that they're given, 70, 80, 90 years, whatever amount of time that there is there, they rely on a healthy supply of nutrition to get there. So there's a highway that leads blood from the heart to the organs. Those are the arteries, simply put, right? And then there is a highway that takes the blood from the organs and delivers it back to the heart. That's the veins. So in order to have, firstly, and simply put, the access to nutrition to our organs, our solid organs, we have to have a highway to the organs, the arteries that are nice, open, and unclogged, right? So that's point number one, is that blood vessel health is one of the most treatable and preventable diseases that we can take care of in order to reduce the lifespan of the organs. Because if the blood vessels are blocked and we have atherosclerosis in the blood vessels, that will reduce the lifespan and will cause the organs to age at a faster rate, right? So now let's talk about the kidneys. If we look at the kidneys, we should know that obviously we're born with two. There's one on the right and there's one on the left. And each kidney is actually the height of my fist. The kidney is about that tall in our body, and normally you can't feel them. They're in your back behind your ribs. And the thickness where all the kidney filters are is an area that's that thick. So you have a kidney that's that tall and a kidney that's that thick, and there's two of them, and each kidney has 1 million filters that filter the garbage out of your bloodstream. So you can imagine how tiny those blood vessels are, the terminal endpoints. So when we look at the kidney and we look at the entry point of the kidney, and so if we've ever dissected an animal, if we've ever seen what a kidney looks like inside the body, we recognize that each kidney has 3 tubes that connect the kidney to the rest of the body. 2 of those tubes are blood tubes, and one of them is a drainage tube. And so, if you think about it, there is dirty blood that our body produces. That dirty blood goes into the kidney. Then there's another tube that carries the clean blood from the kidney, and then there's a drainage tube that carries all the garbage and drains it outside of the kidney into the bladder so we can excrete it, right? So when we look at kidney function, think of kidney function as like a washing machine, right? So what happens? So you have a washing machine and you set the washing machine to the rinse cycle. You take dirty clothes that have stains on it, you put the clothes into the washing machine, you turn on the rinse cycle, the water comes in, there's stains in the clothes, and then you do the whole rinse cycle. Then the water leaves, and when you pull it out, you've rinsed your clothes, but the stains are still on your clothes. That's rinse, right? If you want to wash the clothes, you put the laundry detergent in there, you put the clothes in there, water comes in, it mixes everything up, and then so clean water comes in, clean water plus all the dirt and filth leaves, and you remove the clean clothes. Similarly to the kidneys, you have dirty blood going in. There are patients who are on dialysis that are making normal amount of urine, right? So dirty blood is going in, dirty blood is going out, but they're making good amount of urine, so they're rinsing the blood, they're not washing their blood, right? So if one of the functions of the kidneys is to wash the blood, then how are we to assess whether or not the kidney is washing the blood? So I hope that analogy made sense, that we have rinsing capacity and we have washing capacity. So there are patients who are in my dialysis unit that say, Dr. Ahmed, you say that my kidneys aren't working, but I'm making normal amount of urine. Well, I tell them that if we look at your blood test, that shows that the garbage levels and the stains in your blood are very high. So you have dirty blood going into your kidney, you have dirty blood leaving your kidney, so there's no cleaning that's happening. You're just rinse whatever you're drinking, you're peeing. So you're rinsing your blood. You see? So there's two parts. There's rinsing of blood and then there's washing of blood. So with regards to assessing kidney function, we assess kidney function by way of a blood test that's done by just random blood tests. You don't have to be fasting or anything like that. You just have your doctor check a test called a basic metabolic panel. As part of the basic metabolic panel, there's a lab test called a creatinine. Now, creatinine is a marker of the filtering job of the kidney, how well the kidney is doing it. So when you look at your lab tests, your doctor gives you a printout, and you look at this lab value called a creatinine. The creatinine, that level that is normal, is less than 1. Anything above 1 is considered abnormal. So why is that? Over 100 years ago, the scientists asked the question, what does the kidney do? Well, it cleans out the garbage. Okay, well, if it cleans out the garbage, how do you measure kidney function? They said, well, why don't we just measure the garbage levels in the blood? And if the garbage levels in the blood are high, then the kidney's not doing its job of getting rid of the garbage. Makes sense, right? So then they said, well, how do we measure garbage in the blood? So then it turns out there's a lot of garbage molecules that are there in the body, but in order for us to test for them, it's very expensive to test for all the garbage. So what they said is, what is cheap to test but has the same electrical charge and has the same molecular size as garbage? And they came up with this molecule called creatinine. So if the creatinine levels in your blood are high, that means that the garbage levels in your blood are high. That means the kidney is not filtering out the garbage, so it's not doing its job. Does that make sense to everyone? So hence, creatinine is a marker, is a surrogate marker or an indication that when the level is above 1.0, that the kidney is not doing what it's supposed to do. Okay? And so that's how we measure the kidney function. Now, in terms of when I see a patient and I am asked to discover what the cause of their kidney dysfunction is, when we look at the kidneys as we talked about, there are two tubes that are blood tubes going in, the arteries going in with the dirty blood, and there's a tube that's carrying the garbage, the clean blood after the garbage has been removed. That tube is carrying that blood out of the kidney. So there's a tube that drains all the garbage, just like in the washing machine. You have a drainage tube that goes out. There's also a tube that drains the garbage that's been removed so it can be pushed into the bladder and you can excrete it. So similarly, when a patient comes to me and their doctor assesses that they have some problem with their kidney, the question I have to find out is which part of the kidney is not doing what it's supposed to do. Is it the blood compartment? Because there's a compartment where blood exists because blood is going in and blood is coming out. Is it the urine compartment? There's a tube that's bringing the urine out. So is that the problem? Or is there a problem with the compartment in between those two compartments? So there's a blood compartment. There's a variety of number of diseases that would lead to a problem in the blood compartment. There's a compartment in between. That compartment is called the interstitial compartment. Inter means between, stitia means tissues. So the compartment between two tissues, the blood compartment and the urine compartment. That compartment, when that has signs of disease, again, it will lead to an elevation in creatinine. So the kidney is not doing what it's supposed to do. But there's certain risk factors that people are put at risk for the compartment in between. That's usually medications. Like if you take lots of ibuprofen, Advil, Aleve, Motrin, certain antibiotics can cause an allergic reaction in the kidney. Certain viruses and bacteria can affect that compartment. That's the compartment in between. And then there's the urine compartment, where obviously the tube that drains the urine, we said that's a third of the tube that connects the kidney to the rest of the body. Now, if there's a problem with the drainage of that tube because you have a blockage, as men get older, they have a harder time emptying their bladder, so they have to push harder to get the urine out. So over time, what can happen is urine starts to build up, and it'll back up into the kidney, and it can affect kidney function. So that's one of the common causes of a drainage problem that can occur in the kidneys. So when we draw and we say that there are three main compartments in the kidney that can become diseased, then we have to look at signs, symptoms, and additional tests to see which compartment is misbehaving in our patient. Is it the blood compartment? Is it the urinary compartment, or is it the compartment in between? Once we are able to say this is the compartment, then we can optimize the risk factors and treat that disease of that compartment. Out of those three, the biggest problem that we encounter in the US is problems with the blood compartment, right? So blood vessel disease in general throughout our body is the biggest cause of kidney disease in this country. So as in, whenever you have a disease of blood vessels, like for example atherosclerosis being the big one where you have blockages in arteries, that disease just doesn't affect the heart, it just doesn't affect your eyes, it affects all organs that are supplied by blood, which is all the organs. So all organs are going to be affected equally when you have a diffuse blood vessel disease. So what I'd like to talk about briefly now is, now that we've kind of had just an overall perspective of the three different compartments that are there in the kidneys, what are things that lead to blood vessel compartment issues? The two most common issues in the US that lead to blood vessel disease are hypertension and diabetes. I think you have an endocrinologist coming next week that'll give you a good understanding of what diabetes is. We'll talk briefly about that as well, and that the doctor will give you more details. But hypertension is one of those diseases that unfortunately plagues a lot of folks within our community, and we don't have a really good understanding of what hypertension is and what we can do about it, and what are the different strategies that we have to treat the hypertension. So we'll talk briefly about that. But just to complete the story on the kidneys, we'll get back to hypertension and diabetes towards the end. But to complete the story of kidney disease and kidney health, the first thing we talked about is that this is the size of the kidney. There are three tubes. The function of the kidney, there are many, but the two main functions, or the main function is filtering out the garbage that our body produces and basically rinsing our blood. So whatever we drink, we have to be able to eliminate every drop of what we drink through one of several means in our body. And one of the main means of getting rid of fluid is by peeing the fluid out, right? So we have to be able to rinse our blood. So those are some of the basic functions of the kidney. We talked about the three different compartments. There's a blood vessel compartment. We're going to spend some time talking about the blood vessel compartment because that's the compartment that is most commonly diseased when patients present with signs and symptoms of kidney disease. And then we talked about the compartment in between. The antibiotics and medications are the main, offenders that affect that middle compartment and can cause allergic reaction. And there's the drainage compartment. So what are the tests that our doctors will order to assess kidney health, right? So, and what are the signs and symptoms patients will present with when they have problems with kidney disease, right? There are really three main tests and modalities of testing that we have to assess kidney function. One is a blood test. We talked about what we call a basic metabolic panel, from which we draw the creatinine. And the creatinine, if it's above 1.0, it suggests that the kidney is not cleaning out the garbage like it's supposed to, right? So blood test is one way of diagnosing kidney disease. Sorry. Absolutely. This is a completely informal. I'm fine either way as we go along. Yeah. Sure. I mean, Uncle, you were going to say something. Yeah. Yeah. Inshallah. 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 Okay. So, yeah. Inshallah. Pictures worth a thousand words, right? Right, right. Inshallah. Inshallah. Um, thank you for the suggestion. So there's the blood test. Then there's the urine test. Now, the urine test, the main two things that we're looking for in the urine is there evidence of microscopic blood in the urine? If it's gross blood and you pee blood, you know there's something wrong. That's not a mystery. But if there's under the microscope, you may not be able to see the blood, but there may be blood cells there. So if there's blood there, then we have to ask, is it the kidney that's oozing the blood, or is it the drainage system that's oozing the blood? That's the job for the nephrologist to figure out, right? There's a certain way that we look at the blood in the urine. The third way is the ultrasound test, which is basically a probe that sends out sound waves, and we can assess whether the kidney is healthy or not, whether there's a drainage problem or not, by looking at the picture of the kidney and how the kidney looks. Those are the three main modalities of testings. Now, unfortunately, symptoms wise, there's just not a lot that would point to the kidneys. So this is what we call it. There are certain diseases, certain organs that are called silent killers, like hypertension being one of them. You don't know you have it if it's been long standing until you check the blood pressure and you notice. Just 2 weeks ago, I had an elderly patient, who presented to me, and I said, "How high was your blood pressure when you first came to the doctor?" He said it was 190 over 120, and I said, "Did you have any symptoms?" No. I just came in because it was just a regular checkup, and lo and behold, he had advanced kidney disease because the hypertension was unaddressed and unchecked and untreated for that duration of time, right? So unfortunately, for the kidneys, we don't have any symptoms that tell us if you have this symptom, you have kidney disease. It's not like that. That's why we have to get blood tests done, and we have to look for kidney disease if you have risk factors for kidney disease. And we talked about two of them so far: hypertension and diabetes, right? And so, but there are certain symptoms that would clue a doctor into looking for kidney disease, and one of the biggest one is swelling in the legs. So we all, when we wake up in the morning, our legs are skinny. Before going to bed, the legs can look puffy. That's normal. But we're not talking about the day-to-day swelling you might have. We're talking significant swelling where you touch your shin and you're able to make a big indentation there, right? So when you have that significant degree of edema, the 1/3 of the time it can be coming from the kidney disease. So now that's one of the main sort of symptoms that patients can have. The other symptom is hypertension. Hypertension can be a cause of kidney disease, or it can be a result of kidney disease as well. So in terms of symptoms, there's just not that much there that would say you have advanced kidney disease. Edema is one of the things that we look at, and we look at risk factors for kidney disease like hypertension and diabetes that we talked about. Now, when folks have, for example, recurrent multiple urinary tract infection, then we have to look for kidney disease. When someone has multiple kidney stones, we have to look for kidney disease. When people have, uncontrolled diabetes and they have other problems, we have to look for kidney disease. But in terms of something that would say, okay, with this symptom, if you have it, kidney disease, it's not like that, which makes my job that much more difficult, right? Because if someone has chest pain, they will run to their heart doctor and say, "Doctor, can you help me diagnose what's wrong with my heart?" If someone has a hard time breathing, they'll run to their lung doctor and they know something is wrong with their lungs. When someone wakes up and their eyes are yellow, they know they're run because they know the liver is the problem. With the kidneys, it's not like that. So it's kind of it's a disease that doesn't have very clear cut symptoms. They're what we call protean, which means that it's not very clear cut. It's kind of ambiguous, and we have to look for the disease if you have the risk factors. Now, what can we do in terms of treatment strategies once you're diagnosed with kidney disease? And once you have kidney disease, does that mean that you're doomed for life, right? So let's address those questions now. So, with regards to treatment strategies, once the diagnosis of kidney disease is made, then the first step is to figure out what caused that problem, right? Because if we can find out what caused that problem and we address that factor in a definitive way, then we can reduce the rate of progression of kidney disease, right? And so we can slow the rate of decline of kidney function over time once we know what caused that kidney problem, right? Number one. Number two, once we know what the cause of it is, we have to find out what stage of kidney disease you are. Is it a stage that at the first time you see the patient needs to be on dialysis, which is a kidney function of less than 15% or 10%? That's determined by the blood test and so on. And or is it significantly before that, so we can slow the rate of progression and address all the risk factors that are leading that kidney function to go south, right? So once you diagnose and you prognosticate, diagnosis is what's causing it, prognosticating is how serious it is and how likely is this patient going to require dialysis, right? So once you prognosticate it, then what are the treatment strategies for replacing kidney function? So we're not talking about treating the kidneys, we're talking about replacing the kidney function. That umbrella term is called renal replacement therapy, which is basically kidney replacement strategies, right? How do you replace kidney function? There are mainly two main ways. There's transplantation and there's dialysis, right? So dialysis doesn't do anything to heal the kidneys. It basically takes care of the job that the kidneys aren't doing by washing the blood and removing the garbage from your body and basically getting rid of accumulated salt and accumulated edema because the kidney is not filtering out like it's supposed to. So that is a mechanism that we have available to us to basically do the job of the kidney that the kidney's not doing. So replacing kidney function. And then there's transplantation. So transplantation occurs by way of a few different strategies that we have available. The most common ways is you either take a kidney from a deceased donor, so someone who passes away, and that person said that they want to donate their organs, and you have a good immunological match between yourself and the donor, and you might be offered that kidney. Or a living related donor where two people walk in, one person is completely healthy with two healthy kidneys, and that person decides to give up one kidney to a diseased recipient. That patient walks out of the hospital, a day, 2 days later. The person who was on dialysis gets off dialysis, and hopefully, that kidney lasts for a long duration. With regards to what one can expect with transplantation, is that when you have a kidney that is received from a deceased donor, that means someone who passes away and gives you the kidney, that kidney will last on an average of 8 years, and someone who is a living related donor with a good immunological match, that kidney will last an average of 21 years, right? And so, generally speaking, all throughout the country, we have very good transplant centers. The rate limiting step and the challenge for patients on who are wanting to receive transplant is how long they have to wait, because we have a list. And the list in Illinois is about 7 years. You have to wait on the transplant list, or you have to wait on dialysis before you're offered the kidney. And then the wait is shorter in other neighboring states like Wisconsin, where it's a 2-year transplant wait list, and Ohio, which is 2 to 4 year transplant wait list. So those are kind of the basic, tenets of what I wanted to discuss with regards to the structure of the kidney, the function of the kidney, the strategies that we have to address what kidney disease, how kidney disease occurs, what modalities that we have to diagnose kidney problems, and what are the treatment strategies that we have available to us. Now, briefly speaking, I just wanted to give you a couple of pointers on hypertension and diabetes, because those are the two biggest risk factors that patients come in with when they have kidney disease. So when it comes to hypertension, we should know that hypertension is the pressure that's measured in blood vessels that are the arteries. So we said there are two highways that supply blood and bring the blood back to the heart. The highway that takes the blood from the heart and delivers it to the organ, that highway is called arteries, and the highway that brings the blood back to the heart is called veins. And so what is blood pressure? Blood pressure is the actual pressure that is measured in the arteries that are supplying blood to the organs. So what is hypertension, right? And how do we treat hypertension? Most folks don't really have a good understanding. It's kind of an ambiguous understanding of what hypertension is, but I'll keep it very simple. And this is kind of how I explain to my patient. If you take a balloon and you take a fresh balloon out of the bag and you start blowing the balloon up, the balloon gets bigger and bigger and bigger. And as the balloon gets bigger, and you were to have a way of measuring pressure in that balloon, as you fill more air into the balloon, and as the tightness becomes tighter, the pressure in the balloon goes higher. Is that right? So pressure is a consequence of volume of air you're pushing into the balloon and the tightness of a squeeze that is on that balloon. Is that right? So pressure is a consequence of volume and squeeze, right? It's very similar when you measure pressure in the arteries. So pressure in your arteries, that is blood pressure, is a consequence of volume of blood that leaves your heart and the tightness of squeeze that is there on the muscles that line the blood vessels. The muscles are determined what the tightness of that squeeze is going to be, right? So if we take every single organism that has a heart and that has a circulatory system, and we were to measure the blood pressure, that blood pressure that is generated in that organism will be a consequence of two things: volume of blood and squeeze on the arteries. And so what is volume? Volume is salt, right? The more salt you have in your diet, the more blood volume you have, the higher the pressure. The more salt you have, it's like pushing more air into the balloon. That's the more blood volume you have, the higher the pressure. Everybody with me so far? And then there's squeeze. So squeeze is hormonal mostly. So adrenaline, noradrenaline, epinephrine, norepinephrine, these are hormones that tighten the squeeze on the blood vessel, right? So if we had to choose between salt and squeeze, which one has a bigger impact on blood pressure? What do you guys think will have a stronger impact? Is it going to be the squeeze on the arteries, or is it going to be the amount of sodium in the blood? Absolutely. Absolutely, right? Think of it this way. Go back to the analogy of the balloon, right? If you have the balloon fully inflated, it doesn't take much pressure to raise that pressure to the point where the balloon is about to explode, right? But if you deflate the balloon by half, you really have to squeeze to get that pressure up. Does that make sense? Similarly, when you have someone who consumes a very high salt diet and they have kidney disease, which means they can't filter out that salt. So as we get older, our filtration ability goes down. We become salt sensitive, which means that when we eat a gram of salt, we retain a gram of salt. So as we accumulate salt and then we hear something that really upsets us, or we have a really bad dream while we're sleeping, or we have something that causes these hormones to go up, it doesn't cause much squeeze for that balloon to burst and we have a stroke, right? And so, hypertension, when we look at this treatment strategies we have available to treat hypertension, every single medication that is designed to treat high blood pressure can only treat blood pressure by one of two mechanisms. It can either reduce sodium from the body and cause us to pee out sodium, or number two, it can reduce the squeeze on blood vessels. Every single blood vessel, those are the only two ways that they work. So our question has to be, what is the cause of our hypertension? Is the cause of our hypertension our diet that's fortified with sodium? Or is it our personalities of anxiety, fear, anger, and all of those things that's causing our blood pressure to be high? You know? So if you have that problem, zikr and sohbah, people who are very calm, is probably a very good strategy, right? And prayers. And then if you have the other problem, we have to eliminate salt from our diet. Because think about it. What we're doing when we're consuming salt is we're causing a problem that we're having to treat with medications. Maybe we should just not consume the salt, that we don't need the medications, right? And so what is it that causes us to be salt sensitive? After this topic, I'm going to move on to diabetes very briefly. What is it that causes our bodies to become salt sensitive? From the day that we're born to the day that we die, we lose 1% kidney function per year. We are born with about 140%, and every year after that, we lose 1% per year. So when we're 40 years old, you have 100% kidney function. You can take that in many different directions, right? And then every year after that, you lose 1% per year, right? So every year after the age of 40, your ability to go down, your ability to excrete salt that you're consuming goes down by 1%. So when someone is 70 years old and they were eating a gram of sodium when they were 30 and they're eating a gram of sodium when they're 70, they're retaining 30% of the sodium that they just consumed because they're not getting rid of it. Is that right? Right. So hence, as we get older, as we become more salt sensitive, we have to be more cognizant about our diet and looking at the labels and making sure we're eating salt less food. And I tell my patients namak haram, right? So you just can't add salt in your diet. It's not namak halal, it's namak haram, right? And they get that. And number two, the other thing, and now just very briefly, just remember, when you look at your medications for blood pressure, they can only lower blood pressure by one of those two mechanisms. Either they increase you from getting rid of salt, or they cause looseness of blood vessels. Now let's talk about diabetes. So diabetes and hypertension were not problems that existed 20,000 years ago. They're a problem of the modern day, right? So when the sociologists and the anthropologists at Harvard, they looked at why is it that we have hypertension and diabetes to the extent that we do here, but we didn't have them back then, and why is it that hypertension and diabetes are causing problems, particularly in wealthy countries, and where countries where the third world country, they don't have this problem. So that they actually did an autopsy study of all comers who died at a hospital. It could have been a mom that died during giving birth. It could have been a child that died in a car accident or a drug overdose, or it could have been an old person that died in the hospital. And they did autopsies on all these patients. They found that 70% of the people that died had some evidence of blockage in their heart vessels. They repeated the same study in a country that's a third world country where they don't have access to resources, where they don't have cars, they have bikes, they don't have remote control, they have to turn their TV off, they don't have all of the processed foods, And they don't have all of the stress that we have here living in the United States. They have a stress-free sort of environment because they're happy with what Allah subhanahu wa ta'ala has given them. They looked at they did 100 autopsies randomly, and it was 3% was the amount of blockage in the heart vessels. Then no, this now I'm going to give you something, but this is not to say, this is just to illustrate a point. They repeated the study in the United States, and do you know, like cancer, when it's a solid organ cancer, like lung cancer, liver cancer, GI cancer, solid tumors, those tumors are basically the cancerous tumors are basically have their own blood supply, and it causes your metabolism rate to be increased. So when you see someone who has cancer, they start to shrink, they start getting skinnier. You guys all know that, right? When they have long-standing cancer, it's hard to see a fat person who has stage 4 cancer. They're usually really small because the cancer is extracting as much as it can for its own survival. So what they did is they took the same US population of folks who died of cancer, solid organs, and they did autopsies on 100 of them in the US. 0% had heart disease because their metabolism rate is so much higher, it melts all the plaque and cholesterol that they have in their arteries. So hence, it's not to say that cancer is a good thing, but it illustrates a point that we're doing this to ourselves. By diet, exercise, stress, all of those things, we're doing this to ourselves, right? So what is diabetes? So so really briefly, like when I gave you the example of 20, 30,000 years ago, the folks who had the genes that allowed us to hold on to sugars and hold on to sodium are genes that allowed for survival back then. Because back in those days, when they killed a cow or they had an animal, it was a small periods of abundance separated with large periods of famine. So the people who would be able to survive the long periods of famine are the ones that had genes that allowed them to store the sodium, to store the glucose. So they were able to survive the long periods of famine, right? Those genes were protective then. It turns out that some of those genes are actually genes that help them fight infections 20, 30,000 years ago that were common back then. Now, we don't have any periods of famine. All we have is abundance. So the genes that were protective then are the genes that cause diabetes and hypertension now, right? Because it's of our lifestyle and those things. If you take someone who is in a third world country and has the responsibilities, the lifestyle, and you transplant them to the US, exact same genes, they have the exact same genes that the average American does, right? So I think it goes to show that it's nature and nurture, not just one or the other. We have the genes, but we allow the genes to blossom with our lifestyle, right? What is diabetes? So diabetes is basically what happens when, as we start having something called metabolic syndrome, where we basically get fatter and we have bad lifestyle. That metabolic syndrome can be a consequence of multiple things: smoking, bad habits, increasing weight gain, high blood pressure, cholesterol. All of those things basically cause bad lack of exercise, all of those things, exactly. So with metabolic syndrome, what ends up happening is you get something called insulin resistance. Your body's making the insulin, but the tissues that are supposed to use that insulin so that we can take up the glucose, those cells become resistant to insulin, so the body has to keep making more and more insulin. More and more insulin, more and more insulin, and then before you know it, you have this glucose that you're consuming, but your body can't use it because the tissues have become resistant to insulin. So now you got sugar in your blood, right? So when you have sugar in your blood, what is sugar? It's sticky, right? So when you have sugar molecules in your blood, they are by their very nature sticky. You don't have to have glue to stick the molecule to the blood vessel. They themselves are sticky. They're basically glue themselves. So what happens is, as your glucose level starts to rise, fasting glucose above 126, non-fasting glucose above 200, that glucose level remains high and it attaches to the wall of the blood vessels. When it attaches itself to the wall of the blood vessels, the immune system recognizes it as an abnormality and it starts to attack that area. So then you get disease of the inside of the blood vessel, and that's what leads to blood vessel disease. Okay? So diabetes and high blood pressure are the things that lead to blood vessel disease. Blood vessel disease is what leads to heart disease, brain disease, strokes, and kidney disease, dialysis, right? because those organs rely on a healthy supply of blood going to them in order for them to function normally. So, what can we do? If we have diabetes, if we have high blood pressure, if we have kidney disease, are we doomed or is there room for improvement? Absolutely, there's room for improvement. I will tell you that I have had 76-year-old man who presented to me. He was on a list of medication that was like 3/4 of a page. And I saw him and I said, listen, your biggest problem is that you're almost 300 pounds. If you can lose the weight, then you won't need to see me anymore. We're going to see improvement. So after 6 months of really working with this guy, he quit smoking in his 70s. He quit smoking just with diet alone, no exercise. He lost 125 pounds. I discharged him from my practice. I took him off all of his medications. Okay? So when you see your doctors and you have a list that's a page long, there's something wrong with that relationship. Your goal should be to reduce the number of medications, not add medication, because every medication has a side effect. So anytime you're given a medication, your question is, why am I on this? What do I need to do to get off of that medication? Right? So that strategy has to be ingrained. Okay? And there's the point of no return is so far from most patients, but in their mind, they've already determined I've already reached the point of no return. Right? My patient came to me and he said, Doc, I was born fat. I was fat in elementary school. I was fat in high school. Everyone in my family is obese. I'm going to die fat. I said, no, it's not how it works. You have to take the bull by the horn and you have to realize that God brought you into this country, given you these resources. This is a non-Muslim guy, giving you these resources. And it's your job to take advantage of them because this is a trust that God's given you. You got to take care of it. And he really took it to heart and he lost the weight. Patient number 2, and I'll end right there. This is a guy who was a high executive for one of the large hotel chains. He was a guy who, has had diabetes for 31 years. And he did everything that he was supposed to do to control his diabetes. So that the first day that he came to me with like an Excel spreadsheet with all of his blood pressures, his protein in the urine, his blood test for literally the last 20 years. All averaged out. Perfect record. He says, Dr. Ahmed, I have done everything the doctors have told me to do, and now my general doctor is telling me that I have kidney disease. Like, why did this happen? I said, you know what? You're absolutely right. I said, when is the last time you had an eye exam? Because the eyes, they are the window to the health of blood vessels in your entire body. Because there's only one place in your body where you don't have to cut skin or do a biopsy to look at the health of the blood vessel. You just have to dilate the eyes, and you can directly look at the arteries in the back of your eye to assess the health of blood vessels. So if those blood vessels have diabetes, you can be rest assured there's diabetes in the kidneys. If those blood vessels have high blood pressure, you can be rest assured high blood pressure is also going to be evidenced if we were to do biopsy your kidneys, right? So he said he had a eye exam done 6 months ago, and there was no evidence of diabetes there. And I said, well, you're due for an eye exam now. Why don't you get your eye exam done, and we'll take it from there. If you don't have diabetes in your eyes, then I'll do a kidney biopsy. I'll do $1 million workup. We'll figure out what's going on so we can treat the non-diabetic cause of your kidney disease. But if you have diabetes, we'll address that. So he goes and does his eye exam, and he has early diabetic eye disease, right? And he has early kidney disease, and he has early protein in the urine. So hence, if you have it here, you're going to have it there. 93% chance, according to the Columbia University studies, right? So what I said is, do you know what we measure diabetic treatment success by a blood test called hemoglobin A1C, right? Anyone who has diabetes is familiar with that test. It is a report card of how well your diabetes has been controlled for the last 3 months. The normal hemoglobin A1C for someone who does not have diabetes is less than 5.5. As it goes above 5.5, your glucose is a little bit higher. As it goes above 6, you have impaired glucose tolerance or prediabetes. When it goes above 6.5, you've met the criteria for diabetes. So his hemoglobin A1C, according to the current recommendation, is to keep it below 6.5, and he did that. Like his hemoglobin A1C was 6.2, but I said, do you know what the hemoglobin A1C is for the one who doesn't have it? It's 5.5. So I said, I wouldn't do this on every patient because there's more complications associated with very aggressive treatment of blood glucose, because low glucose is actually worse than high glucose, and if it happens to come too low. But he was a very compliant patient, and he knew exactly what number he needed to have. So very, very, this is not something that I'm generalizing, but this is to illustrate a point of the reversibility of disease, right? So this guy took it upon himself to keep his hemoglobin A1C for 1 year under 5.5. 1 year later, I saw him. His eye disease reversed, his kidney disease reversed, and he has normal kidney function. He has normal eyes now. Does that mean that this applies to everyone? It may or may not. This is a case study of one patient, but I think it does illustrate the point that reaching the point of no return for the kidney patient is dialysis. If you haven't gotten dialysis, there's a lot you can do. For the heart patient is when you have end stage heart disease and you're requiring heart transplant. If you haven't gotten there, there's a lot that can be done. Of course, for liver and lung and brain is one of those things, unfortunately, we don't have a whole lot for. So if you have dementia, khudana khasta, that's the worst thing. Inshallah, none of us, Allah subhanahu wa ta'ala will test us with that. But short of that, inshallah, most of the other solid organs, we have a lot of strategies that we can do to reduce the rate of organ disease progression. So in summary, we can talk for a long time, but I know we're limited with time, so I want to give time for questions. I think the first and foremost concept we have to walk away with is that Allah subhanahu wa ta'ala has given us this amanat of our body from head to toe, and He has given us a way of keeping this trust and keeping it in line so that we can see more Ramadan, so that we can do more sajda, so that we can do more subhanallah, so that we can visit the haramain, right? For as long as we live. So every year is a year that Allah subhanahu wa ta'ala is gifting us as a gift. And we have to take advantage of that, and we have to do what's right to maintain our health, inshallah. We talked about brief strategies of what we can do to prevent kidney disease, and I tried to keep it brief, try to keep it general, and try to keep it simple. Inshallah, we follow along.
Inshallah.
Thank you.
Jazakallah khairan. Yes, you have the blood test. You said the range 1.0.
Yeah.
But my lab results, it says it's
1.2.
between 0.5 to 1.2.
Yeah. The reason why, Uncle, is because the creatinine value is derived from how much muscle you have in your body. Okay? So when we take it like someone like Arnold Schwarzenegger or someone who's a very significant bodybuilder and they have a lot of muscle mass, that creatinine is actually coming from the metabolism of muscle. So the more muscle that you have, the higher your steady state creatinine. For someone like you and me, our creatinine should be 0.7, 0.8 because we have about muscle mass. When we look at bodybuilders, someone who has a lot of muscle mass, that creatinine is a byproduct of muscle metabolism. So the more muscle you have, the more creatinine you release, the higher the normal creatinine value with normal kidney filtration. Yeah. So does that make sense? That's slightly abnormal, yes. Yeah. So for you, a creatinine of 1.1 would be about a 25 to 30% less than what it should be. But take that with a grain of salt, right? Because most of the time when you're getting your lab test done, you're fasting. And when you're fasting for 14 hours, your kidney is dehydrated, so it's not going to show the normal value because it's starving for nutrition. So if you repeat this test on a full stomach and it's still above 1.1, you should see a kidney doctor.
Second question, we have a brother already. Assalamu alaikum.
Welcome.
First of all, Jazakallahu khairan for an amazing lecture. I have never heard such an excellent lecture in such a short period of time. You have covered a lot of things, mashallah. And you kept emphasizing zikr and things like that. And the fact that we are the aman of Allah subhanahu wa ta'ala. I was so glad to hear all of that. In spite of your being a professional in this country. So I have quite a few questions, but I think I've been just limited in terms of time. So I'm gonna try to keep it brief. We'll ask the questions on the side if you have some,
Sure.
or we'll call you or email you something, because it does look like you have an ample of knowledge about all of
Yeah.
But initially you have to thank the people, because Man la yashkurin nas la yashkurillah. Yeah. Thank you, brother. My first question, and thank you for allowing me to ask. You mentioned about creating has to be less than one, but according to some health experts or they actually recommend taking creatine supplement to improve the metabolism, which is going to help you with losing the fat, right? So what's your point,
So,
expert opinion upon that?
So, number one, the molecule that they're talking about is called creatine, and the lab test that we're talking about is called creatinine.
Oh,
Okay, and the creatine will do nothing for you in terms of improving your kidney function.
okay.
Yeah, there's no relationship with taking creatine to improve kidney health.
I'm not talking about improvement. I'm talking about whether it's going to be negatively impacted.
It will. If you take a lot of creatine, it can increase
Oh, really?
your risk of kidney disease. Yes.
Oh, I'm glad that I haven't started it. I'm
Don't
asking
start
you
it.
the question I
No
was
problem.
about.
Yeah, inshallah. Don't. I wouldn't do that.
Okay. Next question. In all of these diseases, you talked about hypertension, kidney disease, and heart disease, and diabetes.
Hmm.
All of them.
Hmm.
What's the risk factor for hereditary problems like hereditary risk?
So, the way that that works is most diseases that we encounter here in the U.S. there is a combination of genetics and nurturing those genes. Okay, so if you have a family history of early heart disease was anyone who had a heart attack at the age of less than 55. If you have a family history of kidney disease, that is someone who's on dialysis, during their life, or if you have a family history of stroke with hypertension, that means that you have genes that predispose you to accelerated risk associated with those diseases. That means you have genes that will cause you, if you blossom those genes with bad lifestyle and issues, then you can cause those diseases to blossom, and you can affect your organs in that same way. So it's absolutely a consequence of your genetic makeup and what you're doing to blossom those bad genes, right? So if you have early heart disease, then there's certain recommendations for targets of cholesterol, target for A1C, targets for your weight, than is different for someone who doesn't have family history. So it just means that you have to be more aggressive with optimizing those risk factors when you have the genetics that put you at risk for those diseases. Yeah. Yes. Modify risk. That's right.
Okay, next question here.
Yeah, it's a general hypothesis like you have to consume 8 glass of water per day to keep your kidney.
Yeah.
Um,
Yeah, that's a really big misconception, actually. So, the way to think of it is that Allah subhanahu wa ta'ala has given us a thirst mechanism to dictate to us when we need to drink water. There are very few situations in which you're obligated to drink a certain volume of water. Really, two diseases that I can think of is something called polycystic kidney disease and kidney stones. In those diseases, you are obligated to drink a lot of water, like 2.5 liters. Other than that, you obey your thirst and you drink to thirst. Because oftentimes I see a number of patients who come in who were told, old wives' tale, that they were supposed to drink 8-10 glasses of water, and they come in with water intoxication problem where the sodium level is too low, and we have to fix that. So if you have a situation where you're dehydrated because you have run or you're sweating and so on, the worst thing to drink is water. You have to drink electrolyte water, like salt water, like Gatorade or Powerade. You have to replace electrolytes, right? So water should be dictated by thirst because we have a thirst mechanism that tells us when to drink. And there are folks who are on medications that when they drink too much water, they're going to get water intoxication. So the 8 classes is not applicable across the board. It won't be harmful to the healthy patient, but it could be harmful to someone who is on medications.
Last question.
Inshallah.
So, is there any age that prevents you from getting a transplant?
Very good question. Yeah. When I was a fellow, this was back in 2005 to 2007, there was an age limit. And the age limit was basically someone under the age of 70, they would get the transplant. Anyone over the age of 70. When I was a fellow, we actually transplanted a 73-year-old guy, and his granddaughter gave him the kidney. And it was a living related donor. They went to end it because he was very healthy. The only issue that arises now is that there is no age limit, right? because now we're actually transplanting organs that are not as healthy to the elderly folks because we have a life expectancy that is not the same as someone who's much younger. You know what I'm saying? So what they'll do is instead of transplanting one good kidney, they'll actually transplant two weaker kidneys. You know, and so there's no age limit right now. There are very few contraindications. The biggest one is if your heart can't survive the surgery, your lungs can't the transplant surgery, your lungs can't survive the transplant surgery, or your immune system can't survive the transplant surgery. But in terms of a hard cut age cutoff, it doesn't exist anymore. But yeah.
Jazakallah khair, Dr. Ahmad, inshallah. We have snacks after two short talks here. Brother Azam will introduce himself, and then Maqsood Saab will talk about the civic duties. So if you want to come over here, inshallah.
Yeah, absolutely.
And some of the brothers here sitting, they would like to know where you are practicing, and they would like to get your telephone number, your contact details, and inshallah we'll go from there. Inshallah. So, with due respect to everybody, inshallah, and the time, Azam Bhai, please come over. So, Azam Bhai is part of our community. He lives in Bloomingdale, and he is going to talk a little bit, introduce himself, and what he is going to represent the Muslim community in general in Chicago, inshallah.
Okay. Assalamu alaikum, everybody. أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. I thank you for sticking around. I know many of us are busy on a Sunday night. Jazakallah khair for inviting me. I'll just be really brief. As you probably know, this year is election year, meaning 2020. It's a presidential year, so it's a big